Hi friends, good evening. I'm Dr. Ashutosh Gupta, and today we're going to talk about aortic arches, right? So meaning thereby that the aortic arch में ऐसा रहता है कि left is left, meaning thereby that the right aortic arch usually dissolves, and the left aortic arch remains, which becomes a normal part, and then the arch of aorta, and then the pulmonary trunk, which makes the isthmus, and then the fuse, and they are usually onto the left side of the trachea. But what happens is this that if the left regresses and the right remains and the right persists, it is called as a right aortic arch, right? And therefore, we can have uh, um, meaning thereby that it can encircle the trachea from behind, and then you can have a U-shaped sort of an arch, and we can have a left isolated subclavian artery, and that is what, and it is called as an RA. So it is a right aortic arch. So if both the arches they persist, and therefore they would form a sort of an O shape encircling, meaning thereby it is completely encircle the trachea from behind, and therefore it is called as a double aortic arch. Right, so we are going to see both these cases, but in our own experience, what we identified is this: that right aortic arch has got and a huge risk for 22q microdeletions. So even though we see these both right aortic arch and double aortic arch on an ultrasound we usually try to triage the baby by looking around for some features that we see for 22q, meaning thereby that we try to see if the facial profile or the tip of the nose or the upturned nose or a mid-face hypoplasia or a flattened faces, or probably we try to look around for the thymus and the nasal bone hypoplasia. So even though we try to look around so exclusively, we have not reached to any conclusion. As a matter of fact, that probably we've identified that the thymic hypoplasia was more in RAA as compared to a double aortic arch and all those stuff. Even though the CMA is being warranted to both the cases of a right aortic arch as well as a double aortic arch, but the yield for 22 microdeletion is more in RAA as compared to double aortic arch. So let us see these videos and then probably we'll talk about. This is the first case. We are doing the anomaly scan, and then we are focusing onto the trachea, and then we are identifying that both the pulmonary trunk and the arch of aorta, they are on the right side of the trachea. So this is the right aortic arch, right? So that's the trachea we're trying to focus, and this is in a 2D scan. So this is the trachea. So ideally they should have been the left hand side of the trachea, but then we are identifying it to be. So this is the right. So this is RAA, right aortic arch, right? So we are trying to put the color onto it, and then we'll see what exactly. So here it is. So we are seeing that it can be an U shaped, and there it is. So this is the trachea, and then they are getting onto the right hand side of the trachea, right? So this is the right aortic arch, and uh, and this is the sagittal view. So we can see both the great vessels and therefore the trachea as a matter of fact. So even though we try to look around for the thymus, and therefore we have seen the thymus even, and but we cannot really rule it out or confirm the presence of the 22q depending upon the presence of the thymus per se, right? So that is what it is. This is a second case in which we have identified that this is a complete encircling of the arch onto the trachea, and therefore what we are getting is a sort of a double aortic arch, right? So meaning thereby the persistence of both the right and the left aortic arch, and therefore what we're getting is a so so that is what it is. And both of them are sort of an aberration of the arches, and then therefore what we can see is this that we try to see for the nasal bone, we try to see for the facial features, we try to see for the thymus. So in the superior mediastinum, even though the thymus is being visualized, and but then it is very difficult to say that probably which of the cases would need an invasive or which will not, right? But in our own experience, what we identified is this that RAA is more associated with 22q microdeletion as compared to this double aortic arch, right? And therefore now we would see the pictorial diagram. So usually it is on the left hand side. So what we can get is a this is a diagrammatic view, and then we can have this 22q microdeletion, which is the commonest microdeletion as a matter of fact. This is what we are getting whenever we are in a 3VT vessel view. So meaning there were three vessel in trachea view. So we try to look around where exactly are the arches going on. So if they are onto the if the arch is onto the right hand side of the trachea, or it is encircling the trachea, it can be U-shaped or it can be complete O-shape, and depending upon we can have a right aortic arch or double aortic arch. So as I've told you earlier also, so probably we try to look around for the baby in varied views, upper nose, tip of the nose, midface hypoplasia, flat faces, prefrontal space, then edema, and then we try to look around for the thymus and the nasal bone per se. So probably we try to triage clinically what exactly that we are dealing up with. But CMA amniocentesis is an invasive, and a CMA is definitely warranted, even though we identified that the yield is more in RAA as compared to a double aortic arch. Right? Thank you very much for your patience.